Hello, everyone, and welcome to the Home Modification Occupational Therapy Alliance HMOTA meeting. Thank you for coming in person and via the web. I hope everyone really enjoys this presentation that we're about to give. Home modifications is such an important field, and it's an emerging field, so it's not been an easy one to really develop. And that's where it's been nice where everybody's been coming together to really help develop the field.
So without further ado, I'd like to introduce Sue Doyle, occupational therapist with her CAP certification and a part of HMOTA. Sue has a private practice in Washington State and extensive experience as an occupational therapy in many areas of practice, academia, and research. Thank you all for coming, and here's Sue.
Okay, thanks, Karen, and thanks for organizing this. I just have one request. Can everyone please make sure that they're muted and stay muted throughout the presentation? Okay, so I'm going to talk a little bit about Medicare and some of the options. Oh, good. Thanks, Nicole. There's sound. That's good. I'm wanting to tell you a little bit about how I got into this. I wanted to retire from the university because I was commuting 3 hours for work and was looking for options. And so I thought, oh, I can do private practice and that's fine. And while I'm getting stuff set up, one of my friends, her husband had a stroke and wanted me to see him. And I'm like, sure, I'll see him. I can't bill your insurance or anything. So, oh, no problem, private pay, not a problem at all. And I happened to be talking to the chiropractor's wife who manages his clinic, who's also a certified biller and coder, and mentioned that. And she goes, you know, it's illegal for you to do that, right? And I went, oops. And so that started this journey. And so I'm going to give you a little bit of my experience and stuff about the journey. We're going to talk a little bit about Medicare rules and guidelines that talk about occupational therapy practice. We're going to describe some possible models for providing services in this situation. They're just examples. There's no rules related from Medicare about how that works. We're going to talk a little bit about how to enroll as a Medicare provider and some of the billing and possible issues that you might come up with service, and a little bit about coder assisting with the service provision. The first part of this that I really want to talk about is why should we even consider Medicare? And as I was looking at setting up my private practice, I thought I'll just do cash pay, not an issue. And I was talking to a colleague of mine who's a physical therapist who owns 2 really successful practices in our area. And I said, I'm not going to take insurance. And she said to me, you know, in our area, you might want to reconsider that. And I asked her to think about, well, okay. And so as I thought about it more, I want to give you some ideas about why we should consider even Medicare as a population we might want to address. In some of that, and we'll talk more in depth, is Medicare tends to set some of the insurance climate. They represent a large proportion of the population of our target market for home modifications. Some of the legalities about billing and what it means for billing for OT services, and some of the current changes, marketplace issues.
Just now. For the people on the online, the sound just went on.
So I had people telling me there was sound earlier.
Oh, okay. I'm sorry. I just had at 7:35. I had a note that said there's no sound.
Several people just said it went on. I saw it flash up.
Okay.
So has everyone got sound? I'm hoping so. If not, put it in the chat, and we have a chat monitor that will let us know. But there's some really important changes that have happened in the last couple of years that make it just perfect timing for OT right now. And if we're not going to step into that place, other people will. So I'm going to talk a little bit about that. First of all, if we think about Medicare and it's setting the climate, one of the things we need to go back is to where Medicare came from and some of the history. Back in 1985, only 50% of people who were 65 and older had insurance of any kind to cover health care. Now it's less than 1% that don't have insurance. At the moment, greater than 50% of all the hospital patients are over 65 and billing Medicare. So think about that, 50% or more of everyone who goes and sees someone in the hospital, it gets billed through Medicare. 12% of Medicare beneficiaries actually account for more than 69% of Medicare spending, and in most cases, that's spent in the last 6 months of their life. When we talk about the impact and look at history of Medicare on healthcare, in fact, Medicare was one of the changing forces that led to non-segregated hospitals and non-segregated wards in those hospitals or units or teams. Because of their policies for billing over 65, people could not make that segregation, and it made a big change in that hospital area. The other thing we see is that Medicare is driving innovation and development of standards and some of the changes. It's setting standards of care. And some of that's really important as we see some of the new changes coming through, because we're going to get an image of where some of the other insurance companies are going to go and what that may look like for us. And then the other piece is right now those chronic conditions, and we'll see more about that afterwards, are overwhelming the system. They're overwhelming healthcare as a whole, but Medicare in particular, and they're looking at ways to change that. I just this last year published an article with colleagues of mine looking at the role of OT in primary care and looking at billing and under the physician's number, and with we'll talk a bit about that later. But in how these chronic conditions are right for OT to actually be in the primary care doctor's office, we're going to talk about the fact that these chronic conditions and the burden that they're placing on the healthcare system now is making it really right for us to be working in home modifications and billing Medicare. The other thing that's happening right now that you're seeing is Medicare is leading the change to move from quantity payments, or that fee-for-service model, to quality payments. And there's some really good incentives and also things that recognize OT in that move to quality payments, and particularly in the move to quality payments for physicians. And so we're going to look as well as some of that. What's the current situation? In fiscal year 2018, and the government's fiscal year starts in October, so there's a slight difference in fiscal year here. The spending on Medicare was $583 million. It represents 14% of the federal budget and is second only to Social Security in terms of the largest spending item in the federal budget. 39 million Medicare beneficiaries on some of this that I looked at are 65 and older. There are 8 million under 65 with disabilities. And there are 10 million that are Medicaid, Medicare dual eligible. And we'll talk about what that looks like in a minute. Initially, 1/3 of the people who are in Medicare are enrolled in Medicare Part C or Medicare Advantage, and we'll talk about that. There was an 8% increase in that enrollment in 2017. These figures were predicting 42% in 42% in 2018. It didn't quite make that. It's about 1/3 of all Medicare enrollments now Medicare Advantage, and we'll talk about the differences in those plans and some of what they're offering. If you look at the overall insurance market, Medicare only seems a small proportion of it. It looks at 14% overall of the insurance market. If you look at that, still about half of people are currently, and this data is for 2017 because there was nothing else that had been put together for later, still half the people have insurance that is provided by their employer. The other thing that you can see there, of course, with the changes under the Affordable Care Act is the increasing Medicaid population. If you look at the numbers, though, on Part A and Part B Medicare, and you look for the years 2016, you see 57 million that are under Part A and Part B Medicare. And if you look at those, 48 million were aged and 8.8 million were disabled. Prime market for the populations that we're looking at. That has grown, and if you look at the calendar year 2018, that's grown to 59 million altogether, and 51 million of which are aged, and 8.6 million with disability. And of those, 38 million are on traditional Medicare. We'll talk about that, or original Medicare, as we look at it. But as you can see, that's a large number and a growing market. That mirrors kind of the increase in baby boom, people who are retiring. So who is eligible for Medicare? And I think people don't necessarily always understand what makes you eligible. You have to have a qualifying work history of 40 calendar quarters, or if you're over 65 and your spouse does, then that allows you to qualify for Medicare. It gives you Medicare Part A technically free, and then you need to pay for B and D. With that, you have to be age 65 or older, or if you're under 65, have been receiving Social Security disability for 24 months or more, or have a diagnosis of end-stage renal disease, which needs to come with regular dialysis, on the kidney transplant waiting list, some of those criteria for that, or having a diagnosis of ALS. Either of those two put you immediately onto Medicare. Dual eligible, and this is kind of important as we look at this because it is another market that we can look at. When you look at dual eligible beneficiaries, these are beneficiaries that can receive both Medicare and Medicaid, and there are different reasons for that. According to AOTA Regulatory Affairs, and I've put links in here that you can access, 1 in 5 Medicare beneficiaries could be dual eligible. So what that means, they're enrolled in Part A and Part B Medicare, but they're also receiving Medicaid benefits or assistance with their Medicare premiums, or there's some kind of cost sharing. There's several programs for which person can qualify to be dual eligible. So they really depend on income we'll look at, they depend on why you qualify, and there's a range of what they do. Some of them, for example, the client that I was just referred today, all Medicaid does for this particular client is cover the Medicare Part B and Part D premiums, does not offer any additional benefits. But for some others, it does offer additional benefits. And what happens is you bill Medicare first, then Medicaid will pick up the co-payment and some of the other options because technically they're the payer of last resort. But if they're eligible for Medicaid benefits, not just Medicaid subsidies for premiums, what you will find is that Medicaid may cover costs that Medicare doesn't, or only partially covers. And for that, it's personal care, sometimes nursing home care beyond the 90 days or the 120 days, home and community-based services that aren't covered. But what impacts us, and we'll talk a little bit more about, is some of the changes in Medicaid policies related to home modifications and DME. Medicaid and Medicare dual eligible benefits vary by state because Medicaid is administered by the states. And so the states have control over that. So again, you have to look at what is the benefits in your state and how are those administered and what they look like. Some states offer Medicaid through Medicaid managed care plans. Other states offer traditional fee-for-service coverage. And some of them, you know, as I said, include benefits or don't include benefits and just the payments. So again, you need to look at taking that into account when you look at that thing. But I wanted to just give you an idea about what this looks like. So for some of our clients, this is important to know that a couple can have an income of $1,400 per month and assets of $11,600 and qualify for Medicaid. And you can see, as well as Medicare, and you can see as you go along, that's kind of about standard. It varies depending on the program that they can qualify under. And there are now state programs that are run through Medicaid that educate counselors and benefit advisors that clients can meet with to look at seeing if they qualify. Now you say that that asset limit is low. I'm going to give you a little picture of that in a minute to talk about what that is. But first I want you to understand that there are some implications if you take Medicaid services when you're on Medicare. And one of that is estate recovery. Medicaid may actually recover the cost of any service provision from the estate of the person they provided that to, with some conditions. There's some protection for a spouse still living in the house, and for the spouse still to have a reasonable quality of life. There's also some protections if one spouse is still living in the community and one spouse is in nursing home and they're covering that extended nursing home under Medicaid. So again, you need to look at what those are state by state. Why is this important to us? It comes to the concept of assets that are viewed as countable or non-countable. So non-countable assets, when we look at that asset number, for some range from 6,000 to 11,500 or more, what they don't include is the house you live in, the car that you have, any furnishings, those kind of personal items are excluded from that assets bank. So it just looks at liquid assets. By the way, it looks at liquid assets back 5 years now because people were looking at hiding assets. But here's what's really interesting, is that home modifications is a really legitimate way to move assets from countable to non-countable. And what that do is may make one spouse eligible for Medicaid to cover their nursing home or assisted living stay, while the other spouse can remain in the home, or to get assistance with premium payments while having the home modified. In some states have limits on the value of the house. For example, Washington State, where I practice, this year the limit on the value of your house is $585,000. Anything over that bumps into countable assets, but it still allows you to do a lot to put money into something that is going to be useful to the client and keeping them in the community and still allowing them to get some support from Medicaid. There are a lot of sites that recommend using Medicaid planning professionals for someone in this situation, but this is where we can market to those Medicaid planning professionals because this is a legitimate moving of assets from countable to non-countable that's also going to impact the quality of life and the ability for that client to stay in their home longer. So this is one area where we could work with Medicaid planning professionals. And in fact, I was talking with our financial planning advisor this week, and he's just in a general credit union, regular advisor, not even a Medicaid planning advisor. And he was telling me this comes up at least once every month or two for him, and he's not even in that area. And so again, potential marketing options here for us. The other piece with dual eligible is that we're now talking about these clients being eligible for some of the new Medicaid waivers and other options that are out there to assist with home modification payments, so that some of the ways to get the changes that they need made in their home covered are now going to be available. Again, this varies state by state, and so you need to check in by the state. In our state, this is all managed by the Area Agency on Aging and Disability under their long-term care planning module. Each state has actually had to look at prevention and wellness under their Medicaid plans and look at how they're going to manage that. They've been mandated by the government to use some of the funds that they've been granted under Medicaid to look at keeping clients healthier, happier at home. So again, one of the things to do, and I've just signed a contract for that in our state, and they're looking at paying $80 an hour, but that includes my drive time, my documentation time in that hour. And one of the things they're also looking at is other clients that don't qualify there for their program, but that they get referred, being able to be seen under Medicare regularly. So again, this is one place where we can get in and market ourselves under those Medicaid plans that are now aiming at keeping people safely at home and reducing the expenses by having them move into institutions, retirement centers, nursing homes that Medicaid is picking up the bill for. Yes.
You mentioned that we can use HMOTA for spend down for Medicaid. Each state is the state program. Each state have a different definition of which individual HMOTA would count for spend down.
So the question was using HMOTA for spend down, and does each state have different rules? So what is counted as countable and non-countable assets is actually mandated by the federal government. Some of those levels do vary a little bit state by state, as you could see. Alaska and Hawaii had some different, I think it was Alaska and Hawaii on there, had some different amounts. The other piece that is altered by the state, those are federal amounts, by the way, that chart's put out federally. What is altered by the state is the value of what some of those non-countable assets could be. For example, the home. So Washington State sets it at $585,000 this year. Each state will have a varying level of what that house could be. But the ability of moving it for home modifications for safety, not a problem. Where we would come in is we actually would, as therapists making those recommendations, it could actually be very easily demonstrated that this was a justifiable spend down, that they weren't trying to hide assets, because now they have a therapist's recommendation that these modifications were necessary and essential. So it's not seen as a way for hiding the assets. Does that answer your question and make sense? What is Medicare? Just a refresher. There's Part A, B, C, and D. So when we look at Part A is hospital insurance. It covers your inpatient care. It covers your first stay in a skilled nursing facility. It covers hospice care and covers some home health services. So traditionally, OT and PT home health are usually billed under one part of Part A that doesn't affect Part B therapy requirements, or under a different form of Part B. Part B is what we call as outpatient services. So that is when you go to see your doctor in his office, not in the hospital. When you go to see a physical therapist, an occupational therapist, those are all billed under Part B. And this is where we're going to be able to bill, and we're going to talk more about that. There's also some DME stuff under there. We'll talk a little bit about that, and some preventative services now are required to be provided under Part B. Part C is the Medicare Advantage programs. And what's happened is Medicare has contracted these out to private insurance companies. And in theory, they are supposed to provide exactly the same Part A and Part B services and Part D services to their clients. And they may add other supplemental benefits to that. And we're going to talk a little bit more about some of the new supplemental benefits that are put in under Part C. And Part D is the prescription drug programs. Those are Medicare approved by private companies that provide outpatient prescription drugs, and they have to follow certain Medicare national rules, but they may only offer services in certain areas of the country geographically, as we look at that, and for certain types of clients. Just a quick talk about durable medical equipment that's covered under Part B. And I did as much researching as I could on what's accepted under there. I need to go back and again ask my MAC provider on this question. But what I could find on all the prescription stuff was it has to be medically necessary, and it has to be for use in the home. All right, so it can't be If it can incidentally be used outside of the home, that's okay, but the primary purpose has to be inside the home. And we need an MD or provider prescription for it. Generally, the covered items under this are commode, hospital bed, pressure relieving mattress, cane, walker, wheelchairs, though there are some very specific other requirements if you're doing wheelchair prescription, and patient lifts. But they did not specify what kind of patient lifts or how expensive. So this is one that I really need to explore more with the local MACs. And we'll talk about what a local MAC is later to see exactly what the parameters are here, and ones where we could push the barriers if we're looking at even ceiling lifts and stuff for some of our clients, because right now where I live, I can actually get a ceiling lift in a client's home for the same price as I can get a Hoyer lift. And so that really makes a big difference in terms of safety, one person being able to manage it, and accessibility, and also saving floor space. So there's a lot of nice options with that. It's really nice because we have a ceiling lift company right near where I live. Their father had ALS and they designed these lifts. And so they take them back, refurbish them, and everything else when the person no longer needs them or the family no longer needs them. So I can get those in for a few $1,000s easily, and a good Hoyer lift can cost me that, and can be much harder for an older spouse to use. So again, awesome. Yeah, it is awesome. Again, now going back to Noridian, who's my intermediary, and asking, can you cover this instead of that, is going to be the question. The other piece is Part B, aside from that DME we talked about, really has no other coverage for the home modifications. I'm not talking about the therapist here. I'm talking about actually paying for a ramp or paying for the grab bars. Those weren't mentioned in the list of DMEs. So again, we're going to need to look at some education here, and I'll tell you why in a minute. And going back to our intermediaries and making the case. Medicare Part C, and what was Medicare Part C? The Advantage plans, that's right. So Medicare Part C started something interestingly on the 1st of January this year. They now have funds available for retrofitting the home to support a beneficiary in their home and reduce the use of service. And they have specifically listed in their guidelines that those include things like grab bars, shower modifications, and ramp installs. And those ones are specifically spelled out in the guidelines. Their focus particularly is on integrating dual eligible clients, but all other clients as well. They have broadened their focus to look at psychosocial determinants of health. So when we talk about the other options that they've put in here, they're looking at transportation to appointments. They're looking at delivery of meals for a diabetic patient so that patients actually have compliant meals. So they're looking at a broad range of options because they've studied those and found that this is actually reducing their overall costs. But home modifications was mentioned as one of those. The slides are all available. You were emailed a copy of where they are already, yes, so you can pull them down. And so this is really key because not only were they looking at the social determinants from the people need transportation, people need healthy meals, people need socialization, people need home modifications, and people need OTs to come in and do that. And fall prevention and falls were highlighted, and we'll talk about why, because Medicare itself put that in there, as well as cognitive impairments and chronic conditions. So you can see that under the Medicare Part C, or the Advantage plans, there's now this opening up for OTs to be able to come in and prescribe those. And now there's some finances and money available for our clients to get the services that they need. What we need is for not the nurse to be prescribing that and the builder to be coming in and doing this, but the OTs to be really active and in there and marketing that piece. The other thing to understand about Medicare is that Medicare is national, right? But there's someone in between you and CMS. the Center for Medicare and Medicaid Services. And that person is called a Medicare Administrative Contractor, or a MAC. And you'll hear me talking about MAC. They're a private healthcare company that works as an insurer that has been awarded geographic jurisdiction to process all of the Part A and Part B claims and the DME claims for any of the fee-for-service beneficiaries, right? So they process the claims, handle and make payments. Advised me the other day that my bank account had been closed and they couldn't deposit the money they were supposed to for me. And educate providers on how not to make that happen again, and other pieces, answer provider questions. I have to tell you, my intermediaries have been amazing, and we'll talk more about that as we go along. They actually have made my life so much easier, and they're important to know who they are. So there's a map here that tells you who your intermediary is. I am in JF area. So that what that tells me is my intermediary is Meridian. And when I go to look for fee scales, I need to look for fee scales. And when I go to look for rules, I need to look for them that apply to JF areas. But this is the first place to start, is to know who your MAC is. And so as we're looking at this process, that's going to be important information for you to contact and keep in mind. Now let's talk about what's covered for OT under Medicare. You know, the Act, and I've pulled at two things here. So the slides you'll see with the yellow band on the right, those are the bottom link. They come directly from CMS as one of their educational program slides. And the other one comes directly from the Medicare manual. Under regulations and downloads, you can see it there. It talks about therapy services are a covered benefit under the Act. Therapy services may also provide incident to the services of a physician. And I'll explain that a little further later on. Covered therapy services are furnished by providers, by others under arrangement, and include physicians, enrolled therapists, etc. In what this means is that anyone who requires occupational therapy who has Medicare insurance, Medicare's obligated to cover it, provided it meets certain requirements of the rules. And those are that it's reasonable and necessary to treat the client's illness or injury. I'm going to talk a bit more about that coming up. In those services, even billing under Part B, not as a home health agency, those services can be or should be furnished in the therapist or group's office and in the patient's home or in the patient's home. So again, the rules open up for us to be going to patient's home as a private practice OT, billing under Part B, to be working with our clients there. And you've all heard about therapy cap, right? Which no longer is, thanks to AOTA. So it used to be up until last year that, you know, you would get to $2,010 and that's it. You'd have to indicate on the claim if it's still there, and they would get denied, and you'd do an ABN and a few other things. What happens now is that cap is sort of still there, in that up until that point, you have to cover medical necessity in certain ways, but once you hit that point, you have to identify it in your codes with coding with still the KX modifier. Up until then, if you're under straight Medicare A and B, the patient is responsible for, or traditional Medicare as it's called, patient is generally responsible for 20% of the scheduled fee after their annual deductible of $185. Dual eligible patients will have limited or no co-payment options, again, depending on how they're dual eligible and what that looks like. Medigap or Medicare supplement clients will generally have co-payments covered by their supplemental insurance. Now, we've talked about Medicare Advantage. Does anyone know what I mean when I say Medicare supplement? Right, so, sorry? They're different. So Medicare supplement is an additional insurance that traditional Medicare beneficiaries, those on traditional or original Part A and Part B, can then apply for, that will help them with that 20% copayment, and may also cover glasses and occasionally dental and some other things like that. And that's an additional monthly payment that they make. What happens, for example, I just did home visits on a client who has traditional Medicare and then had United Healthcare as their Medigap insurance. So for the home visit that I did, I think they paid Medicare paid somewhere for the first visit around $97, and their supplemental paid another $120 or $130. I mean, another $20 or $30 for that. So overall, I think for seeing this client and doing some things in her home, you know, my billing was around $500. Of that, the client paid not a cent because Medicare paid the first part, and then her supplemental insurance picked up the copayment. So that's the Medigap or Medicare supplement program. Very different to Medicare Advantage or Part C. Medicare Advantage or Part C actually provides some limits. Even though it's supposed to give all the same benefits, you often need pre-authorization for visits. Those aren't administered by your MAC, so you can't ask questions there. It's administered by each of the plans. And right now, one of them that I've been trying to work with is Humana. And Humana, A, doesn't pay much, and B, won't even register you in your panel. Even though I've applied for 2 years in a row, they say they have plenty of therapists. Even though the clients can't get the same therapists, can't get the services, they're still denying admitting me to the panel. So there are some issues related to the Medicare Advantage plans or Part C plans. They may have a PPO or an HMO structure, and their copayment options may vary. In fact, sometimes for my Part C clients, I find that the copayment that they're paying to visit me, to see me, is actually higher than if they'd had straight Medicare. So for example, a client coming may have a $27 or $30, copayment under straight Medicare. But my clients that are coming in with 1 or 2 of the Advantage plans have a $40 copayment each visit because occupational therapy is deemed as a specialist. So just, again, when you're working with clients, just being aware of having to check that out first. So under the 1997 Balanced Budget Act, and if I remember correctly, this was under President Clinton, certain providers were given the option to opt out of Medicare. They had to notify Medicare in advance. They had to have a certain form of a private contract in place. But only certain providers can do that. And if we looked at the current list, doctors of medicine, osteopathy, podiatrists, optometrists, physician assistants, nurse practitioners, midwives, they can all opt out. On the list, not able to opt out is chiropractor, anesthesiology assistant, speech language pathologist, physical therapist, occupational therapist. We can't opt out. What does that mean? What it means under that act is that we must be an enrolled provider to provide a covered service to a Medicare client. And we must submit the bill to Medicare for that service. In what that act means that we have an option of 2 ways of doing that, but however we do it, we have to A, be enrolled in Medicare, and B, somehow or other the bill needs to go to Medicare for that service. And so let's talk a little bit, because there's a lot of discussion from speech and PT about this and the impact, because they've had a lot more private practice options and have been in private practice a lot longer than us. So some of the questions that you can see here, and I've put, this is by Asha, My patient doesn't want me to submit their bill to Medicare. Can I enter into a separate written contract with them? No, any healthcare provider who treats Medicare beneficiaries must comply with all Medicare requirements, including enrolling and billing standards. True or false? You can provide services to Medicare beneficiaries in your private practice without becoming a Medicare provider if you bill them privately. Well, that's what I thought when I first started out too, until I went back and read the law. And thanks to my chiropractor billing friend who advised me very clearly about the trouble I could be in. Medicare really requires, and you can read here, audiologists and speech therapists. We can put in OT who diagnose and treat Medicare beneficiaries independently to enroll as providers. We don't have the opportunity to opt out. And again, it talks about that. Physicians can opt out. Why can't we? There's a difference between opting out and participating and non-participating. We'll talk about that in a minute, but opting out is not an option. If we see a client who is a Medicare beneficiary for a covered service, and we'll talk about covered service in a minute, we must submit a bill to Medicare in one form or another. Okay, so I got smart. I'm going to call my MAC. I'm going to call my Noridian, who's my local Medicare intermediary, and I called them twice, actually. I called them again last week just to make sure everything applies. So does Medicare cover me going to the home to evaluate, educate, and train regarding home safety, home modifications? My MAC was very clear that this is a covered service. From everything in their law, their reading of it, and their interpretation of the Medicare guidelines, they said, yes, this is a covered service. The only thing that will change is when you submit the bill, you use a different POS code, which is place of service code, from 12 for your office, 12 for your home, to patient's home, to 11 in your office. So that's the only thing. They see this as a covered service. Now, I asked them more questions about covered service, and we'll talk again about this, but it was related to medical condition as noted above. You have a physician who will sign the plan of care. We'll talk about that. But under those circumstances, it must be billed to Medicare as it's a covered service. You must be an enrolled provider. Routine services that don't require skilled occupational therapy and that are not related to a medical condition are not covered services. And so I asked them clearly, if I was doing aging in place, someone like me who wanted to set my home up to make sure that I'm going to be there for the next 30 or 40 years, but we don't have a specific medical diagnosis attached to that, that's not a covered service. All right. And a service that doesn't require my skills as an occupational therapist to put together. So then I thought, okay, that's nice. Let me check with AOTA. Because, you know, I have to say my chiropractor's wife scared me to death about this. I thought I was going to be in all kinds of trouble if I kept up this. So I called AOTA, and it was right when the new billing codes came out, and I was concerned about what that meant for how I would document being in the patient's home and the services we would look at. So when I sent messages to my colleagues at AOTA that I knew, they put me in touch with Ashley DeLoche and Brian Hull, who were the attorney with the regulatory analyst program and coding and payment policy programs. And we spent about an hour chatting on the phone. And they said the new evaluation codes explicitly address the impact of environment on occupational performance. And in fact, the new evaluation codes and the codes adopted by Medicare and the AMA are even much clearer about how the environment impacts occupational performance and the role. And that this is then a covered service for Medicare and within the scope of OT practice and the CPT code descriptions. They just concluded with one very clear warning. If you do evaluation and treatment in the same session, you need to make sure that the delineation between the two is very clear and very clear in your documentation. And we'll talk about that when we look at some of the models for implementation. So having said all that, I go, what kind of trouble am I in, right? Some trouble I don't want to be in, some trouble, whatever. This was not one I wanted to be in. Civil penalties at $2,000 for each violation. Each violation means each time you see a client, one client several times is several, or several time clients one time, where that service would have been a covered service and didn't bill. Okay, I don't make $2,000 every time I see a client. That kind of gets a bit expensive. If I get back in compliance, I actually face a 10% reduction in the payment that Medicare will give me for each service that I give after that. Starts to add up. Then the other piece is that I can also be subjected to exclusion from Medicare or federal programs, either for a limited period of time or permanently. Now, I don't know about you, but if you wanted to get a job, if I wanted to get a job anywhere, in a lot of places, most of the clients I'd be seeing have some form of Medicare or Medicaid. That means that whoever I worked for could not bill Medicare or Medicaid for my services. And in fact, could not allow me to see those clients because they couldn't bill them, they're then providing a covered service to those clients that can no longer be billed and shouldn't be billed. Anyway, it gets complicated. So there would be some problems with that, which I decided I did not want to take on for some reason. The other thing is my PT friend who had a practice there and I were talking, she said, this is a big market in our area. We don't have a really high affluent population. And a lot of these clients to receive these services need to have it covered by their insurance for the amount of costs and things that are there, and to even have any money left over to look at covering any of the modifications that I may be recommending that are not covered under anything else. And so that I'm removing myself out of a fairly large market in our area if I was to do that.
Sue, I have a couple of specific questions relevant here. Do you have time to take
Yes.
them now?
Mm-hmm.
One is, if it's aging in place and not a covered service, can I still bill privately even if the client has Medicare? And do we need an ABN?
So again, I would consult a healthcare attorney, but everything I read in the PT attorneys literature that I've been putting out there for cash base said that we should submit an ABN. And likely they said some cases they submit it for payment and some cases they don't, but again, I would get advice on that. But an ABN at least would be the minimum from what I was reading for that.
And if you're working with a client that has Medicare and Medicare supplemental insurance, you need to bill both.
So what happens is you bill Medicare first, and then it automatically goes to the supplemental insurance after that. And those are my favorite clients. Those and the clients with Medicaid that will cover benefits on top of Medicare, because the client's not out for anything and they're not worried about the cost, and I get to see them and they're less stressed. Okay, so as you can see, there's definitely a role where those services are covered. But I'm going to talk even more about some of the changes that have happened in Medicare itself for the last couple of years that make this even more a covered service, but also tell us the time is right for OT to be really in there and making a stand. And one of that is a new change that came out to look at the management of chronic conditions. And remember, we talked about Medicare setting some of the stage and the standards. Kaiser, of course, has been working in some of this as well. But they have developed a program called Connected Care Management. And it's for clients with chronic conditions. 2/3 of Medicare beneficiaries have 2 or more chronic conditions. And 1/3 have 4 or more, really increasing the cost to Medicare. And they're wanting to look at how can we coordinate those services and how can we do better for those clients and have their care more fully covered. So what they are doing under this program is they're encouraging their provider, particularly their primary care provider, to bill for 20 minutes or more per month for coordinating care in a non-face-to-face visit. So usually this is billed by a nurse practitioner. So to be included in this, the patients must have 2 or more chronic conditions and are at significant risk for death, acute exacerbation. Oh, golly, I've had 4 hours sleep to get here today. So exacerbation, decompensation, or functional decline. Note it says functional decline. Those are the requirements. This is really key because here's a touch point that helps patients think about their health care, engages them more actively in their treatment plan, engages them more actively in their provider when they're not coming for a specific issue, and becomes more conscious of their medication, managing their fall risk, and other self-management tasks. What does that mean? It means coordinating with other healthcare professionals. It means going through some of the health and wellness stuff that we'll talk about. These are the people in your doctor's primary practice that you need to work with. They are being paid 20 minutes or so a month, a good billing fee, to coordinate with you to manage the right services for this client. This is where you're going to get your referrals from. This is a new program. And so this is where you need to look at who is managing the connected care management programs for the Medicare clients that this practice is seeing. And then ask them, do they know about that? Can they bill? Because they can actually bill then for referring to you and putting all the paperwork together and calling the client and saying, this is what we're doing. And it's an incentive from Medicare to look at preventative and wellness, but it's also giving them a financial reward for doing so. And so this is where we can encourage them. We can help solve your problem. We can be part of this. And not only that, you're going to be paid to do this. So that's super exciting. And if we think about the fact that 2/3 of all beneficiaries have 2 or more chronic conditions, that means that 2/3 of all Medicare beneficiaries qualify for this program. And what did we say? There's like 59 million of them right now. The other thing that just happened starting last year is for Medicare Part C. And based on some research that came out, it's called the Chronic Care Act. In looking at some of the things that are happening in aging in place and trying to look at reducing some of the costs there. So these are some interesting studies, and I stole these slides, and I think I put the link in the bottom. These slides are from a presentation on the Chronic Care Act that Melissa Mott-Smith and I reviewed a couple of weeks ago. But it says, notably in 2017, Johns Hopkins researchers found that 42% of older adults with probable dementia or difficulty performing daily activities did not get assistance from family, friends, or paid caregivers. 42% that required assistance did not get assistance. Of seniors with at least 3 chronic conditions and high needs, almost a quarter, 1/5, lacked any kind of assistance whatsoever. Who's the perfect profession to look at how that can be done in keeping clients safe? Nearly 60% of seniors with seriously compromised mobility reported staying inside their homes or apartments instead of getting out of the house. 25% said they often remained in bed. Of older adults who had significant difficulty putting on a shirt or pulling on undergarments or pants, 1/5 went without getting dressed. Of those who required assistance with toileting, over a quarter had an accident or soiled themselves. What a time for us. So they expanded Medicare Advantage or Medicare C services to look at addressing some of this, and I talked a little bit about that earlier. Again, they want the enrollees to improve their health as much as possible, and so for this, they're paying for transportation to get to doctor's appointments, delivering healthy meals, and look what else comes there. In-home safety modifications such as bathroom grab bars, and in fact, if you read the rules, like I told you earlier, it includes ramps and it includes some other things as well. The new rule will allow those Medicare Advantage or Part C beneficiaries, insurers, to offer very different benefits to different groups. So each of the Medicare Part C insurers can offer different options now. They're free to do something different and experiment. This is not going to those who have original Medicare, who have original Part A and B, but this is going definitely to those with Part C. So we've got two different things going on. We've got the care management for chronic care, the case management. We've now got Medicare Advantage that's looking at alternatives that look at fall thing. And then Medicare itself is now working with the providers to look at quality-based care versus volume-based care. And to look at that, they've implemented the MIPS, which is Merit Incentive Payment System, or merit-based. And it's incentives for providing what they call higher level of care. It includes a 5% or higher, some of the percentages are 7% and more, increase in payments depending on the type of service and which year it's in, and penalties if you don't submit data to show what you're doing with the clients related to these. Two of the measures that really apply to us and what we're looking at are the quality measures 154, which is the falls risk assessment, and 155, which is the falls plan of care. All medical providers must annually ask their Medicare clients who are over 65 two questions. Have you fallen in the last year, followed by how often? And did any of these falls result in an injury? And they must record those in their notes, and then they must record them in a database. If two or more falls or one injury fall, the provider needs to implement a plan of care, which is really key because I want to show you what that plan of care talks about in a minute. That MIPS 154 requires the provider to assess other contributing factors to the fall, such as a review of meds, asking the patient if they've had an eye exam in the past year, and reviewing other possible contributing medical conditions or determining the presence of postural hypertension, right? So that's cool. And here's what they're told. The patient should then be provided with a plan of care that includes balance and strength and gait training instructions, advice about vitamin D, and information on home fall hazard prevention. What does that look like? What information are the physicians being given? Well, let's look at what happens here. This is something that is one of the fall risks. I've given you the, it's from the Safe Step program. It's signed off on by the study program, which is recommended by the CDC, by the way, recommended by CDC. Look at one of the recommendations. Patient was counseled about home fall hazards and advised on the benefits of occupational therapy. It's right there in the plan of care. Now we can solve the physician's need to meet this requirement and get them a pay raise. Because we can answer that, right? Now they can say, yes, patient fell, patient had injury, and yes, I've got a plan of care. Not only did I review their medications, but I referred them to Susie's home modification OT program. This is the one I've used in my marketing, comes directly from the CDC. Again, from the study program, and there's a range of things that are in the program, and it looks at address home safety and how to reduce falls. Notice I put my logo in there with my little card and said, call me, because it says counsel the patient about reducing fall hazards, given the CDC brochure, refer to OT. Again, OT is specifically mentioned here to assess safety and the patient's ability to function in the home. And I worked on some of those other programs. Again, I didn't put the link in for this one. This is available on the internet. It's available for you to print out free, and you can go with your marketing and give it to providers. The new one that's out is the CDC Provider Pocket Guide on preventing falls in older patients. And it's multi-page, but I just cut the 3 things of suggestions. Be proactive Ask all your patients over 65 and assess their fall risk. Identify modifiable issues, and they've listed them there, and then develop a plan of care using effective clinical strategies. And look what's listed. Home modifications led by an occupational therapist were identified that by the CDC as an effective clinical strategy to meet that requirement. They've also just identified this as a medically necessary service that should be covered by Medicare by doing that. So think about this, but it's right there. But they don't know how to refer to us unless we point out to them, here's the options, here's what you can do, here's my card, here's what you do to the patients, you write this in your plan of care, you make that referral, and we're good to do that. What does it mean to say we're covered? I mean, isn't that exciting? Those whole 3 programs now, and we're listed. You know, I mean, we can, and at least in 2 of them, and the other one, the physicians are going to get paid for including us and working with us on that referral. Let's look at defining what is covered, because really we need to look at medically necessary services, non-covered services, and we're going to look a little bit about documenting and identifying medical necessity. This is not a documenting class. I'm going to make some suggestions on that, but I want to go over some of the things that we can do. AOTA made a statement, it was a while ago looking at driving, but it applies to us about what they consider to be a covered service prescribed by a physician, certified by a physician. We'll talk a bit more about that. Delivered by a qualified OT personnel, OT or OTA, and we'll talk about OTAs a little later. Medically necessary and documented according to the Medicare manual instructors and the contractor's local coverage determination. And again, going back to getting your MAC's manual, talking to your MAC provider, those are key because those really determine a little bit. There's some slight variations on how they interpret the rules in each of the areas, but it's very clear. With some things, but some things there's just some mild modifications, and build with appropriate codes and modifiers. It says ICD 9 in that quote. We're on 10 now. What is medical necessity? Medicare normally covers services that are deemed medically necessary. According to Medicare.gov, medically necessary is defined as healthcare services or supplies needed to prevent, diagnose, or treat an illness, injury, condition, disease, or its symptoms, and that meet accepted standards of medicine. What did we just see in all those CDC brochures? Right? That OT assessing home safety and looking at home modifications is evidence-based. The research is there to support it, and it's recommended by the CDC. So it would meet those acceptable standards. Medical necessity documentation, or the lack of it, is one of the most common reasons for denials of claims and payment. For a service to be considered medically necessary, it must be reasonable and necessary to the diagnosis or the treatment of the patient's condition. Medical necessity is based on evidence-based clinical standards of care. Again, the CDC has just done a wonderful job for us and outlined it all. And you can refer to that or put that in your notes when you're looking at that piece to look at your standards of care. I did get, yes?
A little earlier, Karen asked, would OT recommendations be necessarily signed by a physician to be considered reasonable expenses to Medicaid? Can you repeat my question too?
Yes. So we talked about physicians signing OT recommendations for reasonable expenses for Medicaid. And we'll talk a little bit about certifying plans of care and the physician role in that in just a minute. So I'll get to that. There's some slides. The other thing this attorney looks at, how to defeat the government's claims that a provider services lacks medical necessity and fraud and compliance. Susie wrote this, it said, CMS in issuing guidance to the contractors, that's your MACs, regarding the criteria they should use in making medical necessity determinations under local coverage determinations. So that's when the MACs make some rules for their local jurisdictions. specified that a service should be considered reasonable and necessary if, among other things, it falls within accepted standards of medical practice. Again, the CDC has done a great job for us. Additionally, in determining the medical necessity of a service, the CMS provides that the contractor should consider, and this is your MAC, because they're the ones who are going to deny your payment, among other things, the standard of practice within the community and the scientific or research data. Again, the CDC has done a great job for us because they've put it in there that these are evidence-based interventions. So when you're documenting that, the first quote here is by another intermediary called CGS versus Meridian. Visits by an occupational therapist to assess and reassess a beneficiary's rehabilitation needs and potential, or to develop and implement an occupational therapy program are covered when reasonable and necessary because of the beneficiary's condition. Again, anyone that's been identified annually in those visits by the wellness visit by the physician is automatically going to fit that criteria. It should be clear in the documentation that the occupational therapist is working on functional limitations and tasks with the beneficiary. And then WebPT had a couple of people who had successful cash-based practices and a couple of PT attorneys answering some of the questions about that. And they said, be safe and effective, have a duration and frequency that's appropriate based on the standards for the diagnosis and treatment, meet the medical needs of the patient, and require a therapist's skill. And again, this is where OT really shines in that home safety evaluation area. As I said, the CDC guidelines make a case. It's recommended intervention by the CDC, needs to screen falls as part of our documentation. We'll look at that other later, but we can cite those guidelines and fall risk in our assessment. According to the CDC recommended interventions, my assessment is, my recommendations are, and that indicates the efficacy of what we're doing. CGS, again, the other intermediary, had said when you're documenting medical necessity, look at the complexity of the treatment, document any test measures. Again, that fall screening is one, planning interventions and changes, any teaching and assessment of the patient's ability to follow through, and the continued need for assessment and teaching. So show the assistance that they need for learning, the caregiver needs for learning to make this a safe environment, and to learn when you make the changes with home modifications. The key is then to be able to go back with what we know is the research says when we provide DME or adaptive equipment of any kind, even assistive technology to clients, there's a high level of abandonment within 6 months. Part of that is because we've never worked with the clients on how to problem solve when something happens. Who to call when there's service needs, who to call when the batteries go flat, how to change any of those things. It is our responsibility as therapists when we make recommendations for modifications in the client's home that we work with them on how to problem solve or work through training and education on that. So again, looking at those pieces in there where we're changing habits, routines, and roles, we need to again document that education and training and how the client needs help and assistance. Documenting why a treatment is medically appropriate based on the beneficiary's condition. And again, it's really key that we look at the physician's diagnoses and look at what the physician has written, but we also look at what the treatment diagnoses that we're working with, and that they're way more specific, related to weakness, related to falls, related to self-care impairments than just the medical diagnosis, and that we also note the complications and why it may take longer training, why we need to look at contrast, because now we also have a client that has a visual impairment on top of a physical impairment that we need to address. So making sure that we note those in there. Interestingly, some of the private insurance have very different criteria. And I just put this in here for interest. I'm not going to go into it, but one of the things to think about is really knowing who you're billing and what their requirements are and reading their requirements, because, and we're going to talk about the case of prevention and wellness in a minute, and maintenance, but private insurers have a different perspective to Medicare about maintenance because of a lawsuit that just happened against Medicare recently. So just again, I put this in here to really know who you're billing and what their requirement pieces are, because there are some differences to this, but we are talking about Medicare tonight. When you look at some of the MAC determinations for this is again my MAC, Noridian, and they note that accurate coding reflects medical necessity by capturing all the areas, again, what I was talking about with treatment diagnosis, that impact on occupational performance. At both the national coverage determinations and local coverage determinations to look at what codes and billings and reimbursements that they do. So again, getting that manual and reading it and see what the LCDs for your specific MAC are. And now that just seems like I ran off a bunch of jargon, but hopefully by now you know what that means. And selecting specific diagnosis codes helps with justifying the services and justifying some of the changes in the program that we're looking at, or requiring the length of services or the shortness of services that we're doing. So that's really key. What are not covered services? This has really been a struggle in the PT community. And if you go and look at their literature, they've been talking about this for a while, because PTs are trying to, there's a push. They've looked at getting a senator, and I can't even remember which name it is, to put a bill before the House and Senate to look at PTs as a doctoring profession to be able to opt out of Medicare, because they want to be able to operate cash-based practices, and they don't want to go through the insurance billing issues. And so you'll see a lot of discussion if you talk about it. And so I'm pulling up some of that when we look at it here. So examples of services not considered reasonable and necessary. The service could be performed by the patient or by an unskilled personnel without the supervision of a therapist. So one of the things that happened with my friend's husband who had the stroke is that she could do the home program with him. He wouldn't do it for her. He didn't like to do it for her. He thought I was younger, prettier or something. I don't know. He needed glasses probably, but he would do it more effectively for me. At that stage, it was no longer a skilled service. I did not need my therapist skills at this stage because it was routine, etc. But they were willing to continue paying me to have him do his exercise program and follow through with his arm exercises and his scanning and his cognitive stuff. So then I did issue the ABN and continued to see him at a rate that we negotiated privately, because it's no longer as covered skilled service. But I documented in my notes why it wasn't. So it was very clear. At this stage, I wasn't changing or upgrading the program. I wasn't evaluating him for anything. It did not need my therapy skills. It just needed whatever he liked about my Australian accent, or I wasn't his wife, probably, which was the key thing at that stage. One of the things you see in the literature, a lot of documentation with PTs about maintenance programs. Again, we're going to talk about this lawsuit. There were new changes related to this. The key is not that it's maintenance. The key is that it doesn't need a skilled therapist to continue performing the program. A skilled therapist may set the program up. The skilled therapist may review the program at certain periods of time, but that day-to-day ongoing, which we were just talking about, doesn't need that level of skill. Wellness and prevention is another area right now. And again, because Medicare is changing their perspective on that because of the clients with chronic conditions, we have to be aware of that. But at this stage, health education and wellness are not generally covered unless we're looking at issues that are covered either by a nutritionist or by the primary care. Most of those are where Medicare's emphasis on wellness and prevention has gone right now. So if we're offering something different and we can't directly relate it to therapy, then these are considered non-covered services. APTA issued some guidelines back in 2011 about what is medically necessary. So their statement was physical therapy is considered medically necessary as determined by the licensed physical therapist based on the results of a physical therapy evaluation and when provided for the purpose of preventing, minimizing, or eliminating impairments, activity limitations, or participation restrictions. Furthermore, therapy treatment is considered medically necessary if the type, amount, and duration of the services outlined in the plan of care increases the likelihood of meeting one or more of these goals to improve function, minimize loss of function, or decrease the risk of injury and disease. They've made it very clear from APTA that most of what the physical therapist is doing is really medically necessary. And this is a much tighter definition than Medicare. And so some of the PTs have kind of struggled with how are they going to operate a cash-based practice. Well, you can choose to have no relationship with Medicare whatsoever. And this is from a blog by a couple of therapists who run cash-based private practices on WebPT. But you cannot treat or collect payment from Medicare patients for any Medicare covered service. You can, however, treat a Medicare patient on a cash pay basis for non-covered services, which we've talked a little bit about. And some of the literature has some potential options, fitness consultation, gait training, not related to a diagnosis, but things like a running group or, some of the wellness or walking programs, medically oriented gym membership, where instead of having a personal trainer, you have the physical therapist go into the gym with you, aquatics, some therapeutic massage options. But their recommendations was to consult your local practice laws, your professional liability insurance to see what's covered under that, because you're now moving out of your scope of practice that may be covered under your liability insurance, and maybe have a healthcare attorney help you get specific geographic advice, because again, remember those LCDs by your MAC may impact that. And maintain good patient relationships and communication, because where the patient develops a relationship with you for a covered service, they might want to continue with non-covered services afterwards because of that. Again, we talked about wellness, we've talked about unskilled and skilled options. There was a case in 2013 called Jimmo versus Sibelius case, that looked at where Medicare and some of the MACs were using LCDs to look at the service was only covered if the patient was making progress, right? That is now no longer a requirement that can be used to deny or approve services. The requirement is looking at the skill level of the provider is the determining factor. And in fact, in this lawsuit, they had to provide this client and then go back and cover all the maintenance services he had received for that. So again, being aware of some of those options that are there. Again, they're stated, if physical therapy treatment is preventing or slowing a patient's deterioration, this service cannot be provided or reproduced by a non-skilled personnel like a spouse, caregiver, personal trainer, then that service is a covered service, unless it falls under other non-covered categories like fitness. And a physical therapist cannot accept private payment from beneficiary to provide it. Jared Carter wrote some of these. If I remember correctly, he has an ebook, an e-course on it. He is an attorney as well as a PT and runs a private practice that's cash pay and trains other people how to do it. So if you want more information. Yes?
So Medicare doesn't cover grab bars or a stair lift or a ramp. If an OT goes out and installs through the grab bar into a wall or puts the stair lift on the stairs, that's a non-covered service, so that should be included.
That is, but the deciding on that being needed and deciding on where it's positioned and training the patient to use it is a covered service. Yeah.
How do you discriminate?
So our license actually does not allow us to install. Because as OTs, we're not licensed to install something into a wall. So you'd have to, yes.
Would you mind repeating the questions? Because we can't hear the questions.
Okay, no problem. Yes. So the question is, if you went and installed a grab bar and you installed a stair lift, then that's not a covered service. And I said, that's not an OT in our practice law to install those. That installation is then outside, so it's not a covered service. Under Medicaid, a contractor would have to do that service, not a therapist. So then, but the training, the identifying, the positioning and stuff, that actually would be a therapy role and service. So again, looking at how that's distinguished. And again, you know, that's why maybe having two parts of your practice, or, you know, this is where when you look at the capable studies and all of those have a handyman or some other person, contractor, involved with the therapist where they do that role. Yes, so that's where that would look at. That is not a covered service. You're not doing the role of an OT there. That's coming from your construction business part side of that. The other piece with that is, as we looked at here, if you are slowing deterioration related to a medical condition, again, it's all, again, a covered service. You can get a referral from an MD, a nurse practitioner, a PA. The new one is optometrist, and most state laws now do that. And Medicare will cover referrals from optometrists. I've been marketing heavily to them lately and have been getting referrals. And the new one I learned as I was looking at this is podiatrist. And what's really interesting is podiatrists are mandated to report on falls and gait and home safety. So again, looking at marketing to them as another potential source of referrals. And of course, them following through on that plan of care and documenting that is actually going to increase their reimbursement rate from Medicare. So there's an incentive for them to involve us with that. All right. The other piece with this, we'll talk about sign off. State laws may or may not allow you to complete an evaluation prior to providing input. So under our state practice law, I actually can do an evaluation without a doctor's referral. I can't provide treatment without the doctor signing off on the plan of care, particularly if it's medically related, which is Medicare. Medicare gives us 30 days to get a sign off on that. So there is some options around that. It doesn't feel nice for me to say to the physician, I just saw your patient and here's what I'm doing. I need you to sign off on this now. So I always call them first and get their input so that it's a team approach. And again, that's part of where you're working with the care management component or case management in their office, as well as that. But just making sure you're clear about what your state laws allow as well as what Medicare allows. Our state practice law does allow for referral from a chiropractor, but Medicare does not allow a chiropractor to sign off on my plan of care. So if I get a referral from a chiropractor, while I can treat them under state law, I have to go back to their primary care and ask them to sign off on the plan of care. So if I get that referral, which I do try to work with the chiropractors on clients who have back injuries and sustain long-term back injuries and having difficulty with self-care or falls, I also go back then to that patient's primary care and say, I received this referral from chiropractic. Here's what they want me to address. Do you agree with that plan of care? Before I see the patient. Then I'll return my report back to them. How do I enroll as a Medicare provider? Well, as with any good government program, there's lots of forms. I have to tell you though, Medicare and Medicaid were way easier than the private insurance and much easier to get help as you're doing this. And you have a couple of options. You can do it yourself, or you can actually have a billing company do it for you. So in fact, in my area, I found out afterwards, because I thought I could do it all anyway. I tried it on my own. I actually got credentialed on my own, no problem at all, first time. But my billing company that I hired afterwards, because I didn't have time to mess with my billing, could have done it for me for about $65. But I have to have information ready for them. We'll also have a session in April 29 where we'll kind of problem solve and work through some of that and look at some of the things so that we can all potentially enroll. But there are some things you need before you even get ready to enroll. The first thing is you need to determine who your MAC is, which jurisdiction you're in and who your MAC is. The other thing you need to identify is what kind of business structure do you have? Are you a sole prop? Are you an LLC? Are you a partnership? Because that's going to make a difference about how you enroll. I did it the hard way. I went in as a sole prop and now I'm coming back as an LLC to try and redo everything, which is why Medicare called me the other day and said, we can't pay you because your bank account's closed. So my recommendation is to think this through first. And I know some of you already have an LLC. Why it makes a difference is you have to, your bank account and your EIN and your NPI need to all match that. And so you need to get an NPI that's a type 2 for an LLC or a group practice. And you need to get an EIN. And then you need to have a bank account set up for that entity under that tax number. Now, if you are a single member LLC, it will come through straight through on your Social Security, on your Social Security number and your tax that way. So it will still come through like you were a sole prop. It just protects your personal assets a little more, but work with your business attorney or making that decision. But before you want to enroll, I suggest you make that decision instead of having to change partway through. And then you can get, yes?
Can you check if you have an NPI number from another practice setting and it's a type 1?
Yes, your type 1, no matter where you get it, comes with you. Okay. That is related entirely to you as a practitioner. Okay. Where you come in later on is associating it with which practice you're practicing in. And you can actually go in and change that and adapt that. Yes. No, you have to add a type 2. Okay. You can go and add a type 2 in, but then you link your type 1 to your type 2. And you unlink it to some place that you're not currently working for if they've linked it as well. So that is something that you really need to think about. And we can talk about how to do that on that session on the 29th. It's super easy. You get your number really quickly. And it just makes the process go easier if you think about that and have that conversation first with, your business partner, your spouse, your attorney, accountant about how you're going to manage all of that and look at that. You will need to have then your individual NPI, your Social Security number, because if it's not coming in under a business EIN or TIN, then you're going to have to use that to identify payment for tax purposes. Bank account information. So again, if you're billing under a type 2 in a business that's an LLC or PLLC, you're going to need a bank account set up for that. And then you're going to be able to verify that you can use that. They're going to ask you for graduation date and your professional qualifications and the name of the school, which for some of us was a very, very long time ago, since I've been doing this for 38 years now in a few countries. Unlike some of the private insurance where I had to document my work history for all those 38 years, that was a nightmare. That took me weeks to put that together. And then anytime you took more than so many weeks off, you had to document why. I'm going, I don't remember. My kids are 30 something years old. You know, what did I take it off for then? My child I was homeschooling? I don't know. Anyway, so just be aware there's some of that information that you need to have and put together. Professional license information. Since I actually work on the border of Washington and Oregon, I'm currently have active licenses in both states, and I do occasionally treat across lines. So just making sure you have those, specialty certification if you have any, and practice location information. My husband and I decided we didn't want a house address on anything. So we actually, one of the reasons why I got a small private office, I have a room I rent out to a massage therapist, but I have an office where I see a client, but making sure you have some of that. And then the discussion on how you're storing your medical records. I didn't want to store medical records. I've been through this with free clinics. I've been through this with university clinics. I got an EMR because I do not want to carry that stuff around for 7 years or more. But they want you to have documentation of what you're doing there. So I got an electronic medical records. My system cost me $29 a month. It can be unlimited. You can look at some in the exhibit hall here. WebPT, I think for one provider, somewhere around $49 a month. I talked to Athena, who was one I just implemented in the free clinic where I volunteered and was director of operations. And theirs was, they were going to do the billing and take 7%. So they would do my billing as well as store all my medical records. So there's a variety of options you can look around for things like that. Most MACs prefer you to do an online enrollment at PICOS. And the address is in there. So it's picos.cms.hhs.gov, and there's provider enrollment. And you can go in and sign up there. Again, you need to look at group and individual enrollment and which one you're doing. So if you're an LLC, it's slightly different enrollment than if you're coming in as a sole prop. But a single member LLC and a sole prop go in the same way for most of the situations. So if you're a sole owner, which is a sole prop and a single member LLC here, you can, here's my Noridian's advice on what to do. Here's the forms you need to fill in, the sections you need to complete, all the stuff you need to have. And Medicare now only wants to do EFT transfers. So, making sure that you have the banking form and you've signed all of that. Those are all key pieces of enrolling with this. There's another decision you have to make, and that's making the decision of whether you're going to be a participating provider or a non-participating provider with Medicare. You're all enrolled with Medicare. You're a Medicare provider, but you need to look at, are you participating or are you non-participating? Participating means you accept assignment, which means there's a particular rate for that, and we'll look at them in a minute. And you directly bill Medicare, and then once all that's finalized, the patient pays you the 20% and Medicare pays you the rest. Non-participating means that the client generally pays you up front. You still bill Medicare, and Medicare then reimburses to the client. There's different rates for that as well, and we'll talk about that, because under that circumstance, your rate that Medicare reimburses drops, right? Instead of paying 80%, they pay less, and I'll show you that in a minute. But you're also allowed to bill a bit more, which means the client may actually be responsible for up to 35% of the charges. So that's a decision you need to look at. I put a couple of options here because, again, when I started this, I wanted to look at how are people doing this? Who's doing this successfully? Of course, coming from a researcher and a university professor background, I went and looked at what was in the literature. And so the people at St. Louis University had published about this before the Capable study came out, and they had developed the iHope evaluations. So I emailed everyone that I knew there, and they said, this is the person you need to talk to. So that was Emily Somerville I looked at. And I looked at their model for providing care. So they get the referral, they do a screening call. There's no charge for that, of course. They identify the needs, eligibility for insurance coverage or private pay. They look at potential sources of funds and issues related to funding home modifications and others in the home, just some general questions. Then they do the first visit. That visit is split between evaluation and treatment. Now remember, if it's split between evaluation and treatment, you have to clearly document your evaluation part, and you have to clearly document separately your treatment part. Documentation, they did the I Hope eval because they invented it, so of course they're going to use it. They looked at basic client factors, range of motion, vision, strength, balance, etc. And then their treatment focused on education, practice, strategy training. And also at that stage, they were kind of having discussions about placement of rails, placement of some of those things. And they build it under 97535, which is ADL retraining. Sometimes they build under 97537 under this model as an adjunct to also billing the services. Now, what I'm going to tell you is, again, you need to know who you're billing. This works great if you're billing under straight traditional Medicare A and B. Some of the insurances limit the number of units you can bill per visit. So you again have to look at, am I only going to get coverage for an hour? Or can I bill 2, 3, 4 hours and not have any problems? And straight original Medicare with Medicare supplement, you can do that. Under some of the Advantage plans, there's limitations. For example, under private insurance with United Healthcare, I don't care how long I see a patient, they pay me $90. So I really have to be careful about who I'm seeing at what time then. Second visit, this is where they have the contractor come and they join for this visit. The focus again is documenting client education and practice while finalizing positioning of grab bars, changing of things, working through with the family again, and where possible, marking everything up with blue tape on the walls or whatever they're looking at here. Third visit, they continue with the focus on fall prevention, exercise, addressing the fear of falling, which is really big for our clients, and limiting their participation in occupations. And then third or fourth visits, they come 15 minutes or so after the contractor. If small modifications are made to evaluate the usefulness and the impact, and have the client work through those while the contractor is still there to make sure everything went in the same place and where they recommended, and continue training. They certified the plan of care for 90 days. And in fact, when I looked at this, you want to certify for 89 days because 90 days pushes you into a new thing, to allow the contractor to have time to complete most of the work and be able to go through the practice and the training that they need.
So Sue,
What do I do? Yes.
Sue, does that mean that they only get to bill for 15 minutes for the third or fourth visit?
No, they come in 15 minutes after the contractor has started, so that the contractor's already got a couple of things in place so that they can work and practice on those with the client. You bill by 15-minute units that you're with the client, and we'll look at that in just a minute if I don't run out of time. But good question. This screening call, of course, is no charge, but what's really good here is my billing company does all the insurance verification for me. So I just send them the information when I call. They call the insurance, they tell me what the limitations are, what the co-payments are, if I'm covered, not covered, and then I can get back to the client with that information so that when they come in for the first visit, I have them sign, this is what we verified, this may not be what happens, but just to let you know you're responsible about this. I get a brief history, I identify the extent of the possible modifications the client's looking, and any modifications I may need when I'm looking at the evaluation. My preference is to have that first evaluation visit in my office. And the reason for that is that I don't want to spend a lot of time. I want to identify the needs. I want to get the priorities and stuff there. And that allows me to do that because, in fact, the evaluation rate and the reimbursement and my time for writing up is really much lower And so I don't want to get a lot of drive time and other time mixed in with that. Sometimes that does not work because the client can't travel. So sometimes then I have to go and then I have to clearly delineate between eval and treatment in my documentation. And there I may still do some treatment and focus training. I may identify that there's some very simple pieces of adaptive equipment that they can use that will get them through something. Initially, set up the home staff and develop the plan of care. Generally, that's a 1-hour visit with perhaps 30, 45 minutes of treatment time, depending, again, how many eval time, depending on how many modifications to the eval. If I have a client who's got cognitive impairment, vision impairment, etc., that's going to take a whole lot longer, or sometimes just talk way too much. The second visit, of course, is in the home. And now I've already identified the client's priorities. I've already identified their abilities. I already know where they're concerned about it. I've looked at their fear of falling or their history of falling in certain areas. So now I'm going to work in those areas and I'm going to look at what's happening there. So here, this is where I can call that treatment. The other thing, of course, is I'm going through the house. I also want something that's going to take a lot of time. So the new HMOTA app we're working on, or the Home for Life design app, is going to help me reduce some of that time and compile that information together. I save it separately and then pull it into my EMR as a PDF document with everything saved in it. And then in my note, I write my assessment and implications related to my treatment. Third visit, generally with a contractor or a family member who's going to install things that are recommended. And then I do other visits, training, working on falls, working on strengthening. The last client I saw, you know, her quad strength was so weak just being able to stand. So I also did some of that treatment related to that because she needed that to complete the transfers, even if I made the modifications that she wanted in that. When looking at payment, there's some procedural requirements that we need to follow. Again, your LCD from your MAC is going to prescribe those for you, but these are the general requirements. Your state practice law, of course, we talked about. You may not need a referral to see a patient under that, but you will need a signed plan of care to get paid by Medicare. That signed plan of care can be by a physician or a non-physician provider, such as a PA or nurse practitioner. Optometrists may certify, low vision services only. So I'm doing a lot of work in the home now with home safety for clients with low vision, and the optometrist is signing off on those. I've not had one come back from Medicare yet, so I'm not sure with that piece, but they assured me there was no problem when I called my MAC about that. Podiatrists, consistent with the scope of professional services, again, the same thing. Chiropractors and dentists may not refer a patient for services. Now, in my state, a chiropractor, as I said, can, but they cannot sign off on this plan of care. So again, when I make that initial phone call to the client, I find out who their primary care is. I call that doc's MA and say, here's what's happened. Here's the reason. What do you think? Can you send me a referral that you're good with that? The certification is really the physician or provider signing off that this really is medically necessary and this is a reasonable and appropriate plan of care. And there are many ways to do that. If the order stipulates eval and treat so many times a week for this kind of intervention, you don't need to go back to the plan of care, but often the providers aren't really that in tune with what we're doing and they need the support. So I do my eval with a full plan of care on it, and then I have an attachment that I put into, an addendum that I put into my EMR note, and I send it back and say, can you review this? And if you agree, please fax it back to me, signed off. And the requirement is to have that done within 30 days or as soon as possible. There's no specific way to do that. I just find that's better. It's also great marketing. But I need to put some of that up front so they don't have to read all of that. Here's the goals. Here's my assessment. Here's my goals. and then here's what I need you to do. Really clear. The plan of care here has to be under 90 days that they sign off on. Usually I do 30 days at a time with long-term goals that are 90 days. But Medicare requires that they can sign off on the plan of care as long as it's under 90 days. And then you need to recertify if there's significant changes to the plan of care or at that 90-day period. And the plan of care needs things like diagnoses, long-term goals, etc. I am going to skip some of the stuff on documentation because there's some really good AOTA courses about it. But I wanted you to look a little bit about what the fees are and just leave a few minutes for questions. When you look at the eval rates, they're going to change a little bit state by state, again, depending on your MAC. But there's also some cost of living, cost of service provisions and stuff that come into calculating the fees in those areas. So in Washington State right now, if I'm a participating provider, so remember I'm enrolled for all of these, but if I'm participating for the eval, I'm getting paid $93.33. So you can see why I to that. And for a non-participating provider, they will reimburse $88.66. So you can see it's less, but I can charge the client $101.95. And so the client is responsible then for that whole difference on that piece. If you look at ADL training, which is where a lot of my work, is at, if you're looking at that, it's around $35.09 for 15 minutes. And that works out to around $140 an hour. If I look at therapeutic activities, I'm going to look at the definitions of those codes. It actually goes up to $163.68 an hour. That does not include documentation, doesn't include drive time. But one of the things is we need to make sure we're not always billing in the highest reimbursement codes, that we're billing according to the service that we're providing. Looking at getting the correct evaluation code, I would highly recommend this course from AOTA. It's free if you're an AOTA member. Sign up for it. It is well worth doing, looking at how to define the new evaluation codes, make the right choice, because at some stage, Medicare is actually going to pay less for the less complex and more for the higher complex. And we need to know how to accurately document which code we're using, because right now they're taking note of how many of each we're using. And they will check that. While you're there, I'd highly recommend these MIPS courses on merit incentive payment if you're a Medicare outpatient B provider. These are again free, and there's part 1 and part 2. I learned a lot from them. The other piece on that is, as we document, there's going to be incentives long-term that will increase our reimbursement rate as well. Again, looking at making sure that the activities that you're billing match the codes that you're using is key, because if they don't, it's one thing if they do come back and do an audit that they can ding you on, or at least put you up for an audit on that. So the CPT codes are administered by the AMA and copyrighted by the AMA. So just note that they set the definitions of these across a variety of things. Just a couple of general things, and then we'll open up for a few questions. But when billing Medicare, you have 1 year from your date of service to file a claim. I highly recommend you don't leave it that long. Payment may take 30 to 60 days, so there is that lead time about coming back with that. You can bill and create a master claim in most of your EMRs. For example, WebPT, I use Office Ally EMR, and that's what I'm using to start with my claims. You need to manage denials as they come in. I don't have the time for that. It frustrates me, particularly if there's a denial and I have to go back and spend hours trying to figure out why. So I pay a billing company that takes 7%. They deal with all of that. And for me, it was worth it. How did I find that billing company? I asked some local counselors and some physical therapists who they're using and how that's working out for them. But they were really helpful. They send bills to the patients, they collect the co-payments if the patients don't pay me at the point of service. So that is very helpful for me. Just to note that the referring provider needs to be listed on your billing, which is why I always call the office first and make sure they're okay with that if they were not the people that were sending me the referral. And your place of service, your POS, needs to be on there as well. So home is 12, office is 11. There are a lot of other options. And the KX modifier if you go over $2,000, which is about 20 visits or 18 visits. There's a lot on documentation that's here. Again, I recommend you take an AOTA course on documentation, look at the documentation guidelines, and read what's in your MAC. The MAC has a lot of guidelines. The MAC manual has a lot of guidelines on what they want in there and what they considered covered. Okay, I think, Karen, we'll open it up for questions now if we got some there.
I think we should give priority to those who are here. If you have questions, make sure that you get them answered.
Questions or comments.
I have several queued up here so that we can't quite touched on, so I can add those.
Okay. Anyone here have questions or comments?
I'm confused. I was under the impression that in order to even do the grab bar, you'd wind up being in trouble with Medicare. But with this question, it sounds like you could do Medicare, the grab bars without being medically necessary. Why wouldn't it be medically necessary?
So I'm going to paraphrase the question about whether grab bars is a medically necessary piece. I'm going to go back and say installing the grab bars is not something that's within our licensure. And so that's not covered that way. Though, when you look at some of the changes now in Part C, they will pay for someone to install those, right? But that comes from a different thing than us billing as therapists. Us going in as therapists and deciding the patient needs a grab bar and where the grab bar is positioned and what type of grab bar, that's a covered service because that's relying on our skills as an occupational therapist to look at that. So that is
can't do that private pay.
Correct.
Okay.
I would actually, you can ask a healthcare attorney about that and get some more clarification. But where it's a client who has a medically covered condition, it fits. And you can see the CDC has outlined all of that now under those new Medicare guidelines and the new guidelines for the physician, that those falls and fall prevention and home safety hazards is clearly within the scope of Medicare domain.
It seems from what you said, OT better get on board with the Medicare issue, or we're going to be in trouble if we insist on private pay. We're going to wind up being coaxed into it or getting in trouble.
So I think the comment here was that OTs better get on board because we could wind up in trouble with this. I think the scope of Medicare has broadened, and we could either see we're going to get in trouble, or we could say this is a marvelous opportunity now that's identified the need for our services, coverage for our services for a broad range of clients that weren't covered before or didn't have the opportunity. And if we don't get in there and do that, there are some provisions in Medicare that those therapy services can be provided by nurses. And I'd hate to see us lose it with that option. Yes?
So you talk about OT being aspects of it being covered versus non-covered, and you talk about a general aging in place evaluation as non-covered. So what's the difference? What's that really look like?
Again, this is going to be your judgment about, is it related to specific medical condition, working with the physician related to that. If it came from the physician related to their annual falls assessment, then it obviously is definitely clearly in the covered service. If it's someone like me who comes to you and says, I'm now building my house and I want to make sure A, B, and C is in there, that's definitely non-covered. Potentially, since my husband has prostate cancer and a range of other things, there could be an argument made. And then
maybe what if it's like a chronic, say someone has MS and they haven't really had a recent medication or anything, but they just say, oh, I can benefit from this from someone checking out my home to make sure it's safe.
You know, again, there's a lot of gray area, and I'd get advice, and I'm just going to go back to, I did caps with a building contractor, and I ran into him the other day because we had this great relationship. We're going to do all this stuff together, and he was going to give me all these medical cases, and he said to me the other day, haven't had any medical cases. I'm like, okay. He said, yeah, here's what I'm working on right now. I have this patient that's had MS for 30 years or something. She's working crutches, and I'm remodeling her bathroom, and I'm putting in a walk-in tub. And I went, oh my goodness, have you thought about, because right now she's developing shoulder pain, and what happens as she ages in this? And for me, I could see the medical need for my services in there. He couldn't get it. And so again, I think, see, and Medicare isn't requiring that for the wellness visits. The wellness visits are an annual checkup. They're billed differently. They're not requiring an acute exacerbation that's bringing that patient to the physician's office. But they are asking, have you fallen? Yes.
We can only hear you. We can't hear who you're talking to. So it sounds like you're having a conversation with yourself.
Oh, I can do that regularly, particularly on 4 hours sleep. So the question was, what makes a covered, non-covered service? And what if it's a client who hasn't seen the doctor for an acute visit? And what I said there is that annual wellness visit does not require and will not cover any acute visits. So my husband called to see the doctor, and we said an annual visit. He's on Medicare, but he had some specific questions related to it. And they said, we can't do that under the annual well visit because it is an annual well visit. So that's going to bring up the falls requirement. So it really, it's interesting because this has created a dilemma for us, but it's also created a great opportunity for us. And I think navigating that is going to create some questions as we go through.
But so even the wellness component and the prevention component, OT really needs to step into it.
Yeah, so the comment was even the wellness component or the prevention component, OT really needs to step into it. And again, that fall screening and annual wellness visit, not from them going to the doctor for an acute medical issue. And so, yeah, but the opportunities are great. All right, any other questions in the room?
Here's one. So I am a Medicare provider, but do not participate in any Medicare Advantage plans. Can I bill those plans privately?
The answer, so right now, so the question is, I'm a Medicare provider, but not participating in the Advantage plans. Can I bill those clients privately? The answer to that is complicated, and I don't know, because right now I have that issue with a client who has Humana, who Humana will not let me on their board, even though I've been trying for 3 years. And so I'm trying to get advice on that, because it does get complicated, because to bill an Advantage plan, you have to be a Medicare provider, but then you also have to be credentialed with the Advantage plan. So you have to have both credentialing there.
So I was wondering, so how do you get involved with the Medicare Advantage? How do you get the OT?
So the question was, how do you get to be involved with the Medicare Advantage? So what I look at is go to my state insurance board and look at who are the Medicare Advantage providers in my state and who has the greatest percentage of clients, because the state health insurance boards keep that data, and then that tells me who I go after first to want to get credentialed with.
Similar question, if our insurance company is providing medical coverage and a doctor's order for DME is present, or DME or a home eval, can Medicare be charged for that?
So if the car insurance has provided coverage and the incident is coming from an insurance covered event, so that was the question, can we bill Medicare for that? In actually Medicare, one of the questions asked is this coming from another event where another insurer is responsible? So in that case, the first option would be to go back to the car insurer, from my understanding. And then anything denied is not reasonable under them or not related to that incident could then potentially be looked at from Medicare.
Talking about the Medicare Advantage, do you know how much money is allotted for the home modifications, or do they have certain contractors that they're working with? Or?
So the question was, in talking about Medicare Advantage, do we know how much is allocated for home mods? Again, it's going to depend on the plan because each one of them is allowed to offer different benefits. And I've seen some that range from $500 to a couple of $1,000s. Also note that clients may have long-term care plans, and those plans also will offer something towards that. So those are things to evaluate. And one of the screening questions I also asked them, do you have long-term care insurance?
Maybe one more. How is equipment covered under the Chronic Care Act?
So I think, again, that goes back to the Medicare Advantage question that Sarah just asked. Each of them is allowed to offer something different within their geographical region that they're providing. So you need to go back and read what their coverage determinations are under Medicare Part C. And again, as I said, I've seen anything from $500 up to a couple of $1,000s. This is not going to be a $30,000 bathroom remodel.
The other questions are maybe a little more specific. Perhaps we can cover them in a review of the session, or Karen can send out some notes afterwards.
Yeah.
We also agreed to send the materials out to everybody so that you can ensure that you have them.
Yes, you should have received an email today with a link to a Google Doc that has copies of the slides. And then Karen and I are also been talking about having some follow-up sessions to this. To help us work through some of the different questions that come from this. And the first one is going to be April 29, where we're going to look at potentially if people want to know how to get their NPI number and where to get the enrollment forms and what kinds of things to put in there. We're going to look at some of that working session together. But we were talking about different sessions related to the survey information that we got and some of the questions that came from today to have some follow-ups that we can all work through some of the issues together. Has this been a helpful session?
There are many comments online here in the chat session that were very, very grateful for the quality of the information. Many, many thanks.
Thanks. I did work hard on putting it together and trying to make sure it was accurate. Again, if you have questions, you know, my advice to you is at least call your MAC and ask them questions. I have to tell you, my MAC and my Medicare providers, a Medicaid provider enrollment specialist have been so helpful. My Molina enrollment specialist came to my office and sat down with me and said, tell me about what you do and how can I help you? I've never had an insurance rep do that. When I'm a provider, you know, they're not selling me anything. I'm costing them money, but they came and asked about what could they do to help? Was the enrollment process difficult? Did I need any support? What questions did I have? Here's their card, call them. So that process has been helpful with that. And then again, you know, I've just recently, as I said, got contracts with Developmental Disabilities Administration in our state. And again, they just facilitated that all the way through. And it was done in a matter of 3 weeks. So again, just feeling comfortable reaching out and asking questions and finding answers. That's what I've done. And when I wasn't sure, you know, I was able to contact AOTA and ask their coding and regulatory specialists for advice and walk through the scenarios with them as well from that perspective. And I'm still learning. I actually learned more stuff putting this together as well. So I think it's a process of being able to share and keep up to date as
It's still
well.
very nebulous, but having it all kind of together and to direct you to different resources to answer questions that relates to your locale is very helpful.
Yeah, so the comment was putting it all together and seeing it as a bigger picture and getting resources to go ask questions has been helpful. Well, thank you everybody so much.